Good afternoon, folks here. This is a Prenuvo webinar. My name is Dr. Vikash Modi, and I'm actually hosting and introducing our two speakers today. A nice change of pace for those who are probably tired of listening to me talk about all the Prenuvo sciences. So I'm very, very pleased to present today's topic. We've got the whole body MRI screening benefits for the annual physical exam. So just to dissect that for a second, we've got Dr. Shannon Ashley here. She is our senior preventive medicine physician located here in the Atlanta clinic. And then we've also got Dr. Marilyn Galvez, our senior nurse practitioner who's out of Florida. They're going to be speaking about something that's very, very near and dear to all of our hearts, I think, which is the idea that we are still sort of evolving this idea of an annual physical exam to be the 21st century, more insights, more depth. You know, we all remember in medical school and training going through our practicals and doing our clinical knowledge and our clinical skills classes. And you know, we kind of went through the rhythms and went through the patterns. At the end of it, we thought, did I really learn anything from this patient, or was it all theater? Of course we learned things, right, everyone? So the physical exam is, of course, incredibly vital when done well. It can be a very, very useful part of the program. What we're looking at here is the idea of turning our Prenuvo exam into that new version of a physical. The thing that we're looking at on the screen right now is one of our clinics. So just to remind everyone that we are a whole body dedicated MRI screening service for preventative screenings. We now have 22 clinics across North America. Multiple new clinics are still opening, most recently St. Petersburg, Florida. Shout out St. Pete. Our team continues to play a role here in the technical advancements of MRI applications. So our team that is on this call, behind the scenes, a lot more clinicians, we continue to evolve the services that are coming through Prenuvo. And the most beautiful thing, though, is just our experience. So what you're looking at now is one of our actual clinics. I believe this is New York. And this is what your patients will come to expect from us when they come to see us. As a refresher to what the MRI is, it's a 45 to 50-minute diagnostic quality, but still not diagnostic. This is a screening modality, MRI exam. There's no radiation or heavy metal contrast involved in our scans. This is always a quality control from end-to-end experience, meaning that every front desk physician liaison that you'll meet, every radiologist in our staff, every preventative medicine person that you'll speak to, these are all employed and trained by Prenuvo. We own the facilities, we own the imaging centers, the scan machines. So that's a really important piece of our process. And then, of course, our goal here is to empower you, the physician, the provider, to really provide this sort of high-end consultation once all of these results come through. What you're looking at now is our actual machine. This is one of our Philips machines. All of our machines are uniform across the system between either Philips or Siemens. This is a 1.5 Tesla machine. And what you should be noticing are the nice bells and whistles that we've added on. We have these temperature-controlled, cooled beds. An MRI machine can get quite warm and uncomfortable. We have made accommodations for that by having cooling mattresses underneath you. Of course, we can't avoid the coils, so the coils sit on top of the body. But what we have managed to do is equip each room with one of these television screens right behind the MRI machine. That allows you to watch content, whether that's on your streaming services or listening to a podcast. But it makes the experience much more comfortable for your patients. And so within 45 to 55 minutes of getting this scan completed, the patient needs to be aroused from being asleep in a lot of cases. But if they're not asleep, they've been watching their favorite show, listening to their favorite podcast or news series. And then they are sort of released back out into that beautiful waiting room where there's some snacks and there's some hydration involved. And that's when they'll end their journey in the clinic and then go on to the post-scan consultations, which happen they happen after the scan at a 1 to 2 week period. So just as a quick recap here, we are detecting the presence of diseases within individuals on a screening modality. Prime examples are going to be diseases within the vascular systems, like we'll be able to see pericarditis, we'll be able to see enlarged aortas, neoplastic systems, of course, we're looking for tumors and solid masses, metabolic conditions like your fatty liver diseases, and neurological conditions like brain tumors and spinal cord degeneration. The idea that we're trying to enforce is that this is not just a one and done snapshot, but also the idea that there is a sort of longitudinal value to doing these studies over time, which is kind of a different concept for a lot of imaging services. But the idea of repeating your scan and then watching your body change over time, whether that's positively with interventions, negatively with injuries or aging, it's very important for us and our patients to sort of see those changes happening. And we now have the ability to do that with these Prenuvo scans. And then last but not least, we're tracking kind of imaging biomarkers. So again, monitoring the effects of medications, interventions. I think that's a really, really important piece as we get started with our talk today. Just to remind people that, what you do in your clinics is really going to matter to how the images look, and that kind of either reinforces what your patient's doing or helps change trajectory. And that comes back to the entire crux of what an entire annual physical exam should be doing for your patients. So let me turn it over to our two guest speakers, our two expert speakers, I should say, Dr. Marilyn Galvez and Dr. Shannon Ashley. Thank you very much for joining us, folks.
All right. Well, thank you very much for the introduction and the information, Dr. Modi. Again, hi, guys. I'm Shannon Ashley, Dr. Ashley. And Marilyn and I are both really excited to talk about today's topic of rethinking the annual physical exam. And before I even particularly delve into that, I really wanted to kind of take us back a step and talk big picture about sort of where I think that we could be moving in the healthcare system. Basically, if we built a healthcare system that really started to prioritize prevention, I think that the culture around health would change, and in some really powerful ways. I think we'd stop associating healthcare with fear and crisis. Preventive care would shift the mindset from all our patients saying, what's wrong with me, to how can I stay well? And that would be a really big cultural shift. I also think it would start to really normalize taking time for yourself before you're sick. Right now, people, ourselves, we're often feel guilty for prioritizing things like rest or nutrition or even checkups unless something is really obviously wrong. So in a preventive first culture, those behaviors would become, or would be seen, I should say, as being smart or responsible and even inspirational, which would be great. And then from the provider standpoint, the culture between basically our conversation, the culture between our patients would be more collaborative, it'd be more human. I think that as clinicians, we would have more space to really partner with our patients over time and not just treat them in their moments of crisis. So we focus more on the root causes and not the symptoms. So ultimately, in a preventive healthcare system, I think that we would build more health literate and proactive and a compassionate society. And then that's where care could really be about living fully and not just surviving illnesses. So when we get back to what our topic is today, which is a subset under that, I really want us to think of today's session of rethinking the annual physical exam, not replacing it, but augmenting it with a lens that can reveal what even our best trained eyes and hands can't detect. All right. So, but currently, our annual physical exams have become the cornerstone of our preventive care, and that's been for decades. Honestly, probably there hasn't been much changes to the annual physical exam since like the stethoscope was invented. So, today we've got all these great new tools, tools that weren't available when I was back in medical school. And, Prenuvo MRI is just one of those. It's a way to add this depth and visibility to our physical exams, which really help us move from that reactive to proactive medicine, which I know you've been hearing us kind of say throughout this year. The way Marilyn and I are going to kind of approach the topic today is we're going to talk about some of the more common common physical exam cases that come in different phases of like the adult life. And so that's starting with sort of like the young adult in their 20s or 30s. For our cases, we are particularly going to focus on young female patients, our college students, early career women, those coming in for like their well woman checkup exams. And then we're going to talk about the sandwich generation of middle-aged adults, so 40 to 50-year-olds who are juggling with their work, their kids, and their aging parents. And in a similar age group, but a different type of, physical exam or patient that may come in is the person who has a really high stressful job or just a lot of stress in their life, from a CEO to first responder to a surgeon, that person that's constantly on and may not be able to like really take care of their own health all the time. And then one of the most growing populations of patients is going to be the geriatric, or what we like to really call now that proactive aging adult. So this is going to be our likely retiree, someone that's probably 65 or older, but is now really trying to recommit to that, healthy living and longevity. All right, so let's jump right in. Our first case is going to be, like I said, a young female. So, you can think about that 26-year-old or so, mid-20s female that comes into your office. And right now, in a traditional kind of physical exam or annual well woman, we're going to, our focus is going to be getting some, additional sets of vitals on this patient, talking through their vaccine history likely. We're going to start doing some lifestyle counseling. And for that well woman check, we're going to really start talking about reproductive health, getting that pap smear done. Gaps that could occur in this kind of particular patient might be that we're overlooking the potential for congenital anomalies or early vascular changes, or even silent tumors. So there's some really big areas that can be really an additional enhancement if you get MRI at this age group, right? For the female in particular, we might be able to start seeing additional uterine and endometrial insights. So beyond the bimanual exam, our physical exams are limited. The bimanual exam, we can sometimes detect enlarged or irregular sort of uterine contours, but it's subjective. And often we know we're going to miss the smaller or even some deeper pathology that could be going on. MRI tends to provide this direct visualization of the uterine structure, of the endometrial lining, and of the nexa. And that's going to reveal stuff that just our regular palpation, exam can't do, right? So there's other ways of differentiating between even the benign conditions, which is important. So fibroids or adenomyosis, those are often indistinguishable on our exam. And even an ultrasound can sometimes be equivocal for those two. MRI can adequately map fibroid size, number, location, telling us is it in the submucosal versus the intramural versus subserosal, which we all know can correlate to the very specific symptoms that someone might describe when they come into for their physical exam. All right, so I think Marilyn has a case she's going to share that correlates to sort of these kind of additional insights we get about the uterus in females.
Thank you, Dr. Ashley. These cases, this one in particular, highlights the strength of whole body MRI when it comes to evaluating pelvic pain that's otherwise been dismissed or misattributed during the annual physical. This is a 30-year-old woman with a history of fibromyalgia, and she'd been experiencing bloating, painful periods, back pain, and pain during intercourse, symptoms that were all too familiar, yet she had never received a formal workup for these concerns. On her Prenuvo scan, we identified this large left ovarian endometrioma, clearly seen here on both her coronal and axial views. And you can appreciate the size, the complexity, and the structure of the cyst here, something that would be extremely difficult to characterize on ultrasound alone. The arrows here point to the classic appearance of an endometrioma, low signal on a T2 imaging due to chronic blood products, and its round, well-defined shape with shading artifacts that help differentiate it from other benign cysts. What's especially important here is that this diagnosis changed the trajectory of her care. She went from years of vague symptom management, often blamed on her fibromyalgia, to a more definitive gynecological diagnosis that explained her symptoms and allowed for targeted treatment. And this is where our consults evolve. Instead of speculating about possible causes of pain, we now have imaging confirmation of an endometriosis-related cyst. That allows me to guide the patient to the right specialist and to have a real conversation about symptom relief, fertility planning, or surgical options, depending on her goals. From a provider standpoint, this is the kind of patient where whole body MRI fills in the clinical blind spots. It gives us a deeper layer of data that often validates what the patient has been feeling all along, and that can be incredibly powerful. And with that clinical context in mind, I'll pass it over to Dr. Ashley.
Thank you. Very good case there. So, another area that we're going to get some additional insights in is going to be ovarian structure, and sometimes about even ovarian reserve clues that we can get. I mean, ovarian health in general, particularly this age group, is often under-discussed in the context of our annual physical exams. But by using MRI as a tool, we can provide the person with both structural clarity and functional context. So while MRI doesn't directly measure ovarian reserve like an AMH level or an FSH might provide, it does provide structural correlates, though. So it can give information on ovarian volume and stromal characteristics, which often correlate to like follicle density. So I really want us to think of MRI as a window into ovarian health trends for a person. It's not a lab value, but it's a structural map that complements the biochemical markers. And so, Marilyn, you've got a case on an ovarian finding, correct?
I do. So this case is a great example of how whole body MRI can uncover clinically significant findings that might otherwise remain hidden. So in this case, we have a large ovarian teratoma in a female patient who presented only with nonspecific lower back pain. So as you can see in these MR images, there is a large complex mass in her right ovary with a distinctive appearance. The signal characteristics on MRI, particularly the bright signal on T1 weighted imaging and fat saturation sequences, help us confidently identify this is a mature teratoma, also known as a dermoid cyst. What makes MRI particularly valuable here is its ability to characterize tissue composition. This mass contains both fat and fluid, which are hallmark features of teratomas. Other modalities like ultrasound may detect a mass, but they often lack the specificity to determine what it's made of or how concerning it might be. And from a consult perspective, this is kind of incidental but important finding, allowing me to have a very direct and informed conversation with the patient. We're not just identifying something unexpected, we're preventing potential future complications like ovarian torsion, rupture, or even rare malignant transformation. And I find that patients are often surprised by these kinds of findings. They're asymptomatic or attribute their symptoms to something like aging or musculoskeletal issues. But once they see their scan, the conversation completely shifts. We go from uncertainty to clarity, and that's incredibly powerful both for the patient and the provider, Dr. Ashley.
When we think of reproductive health, similar to the two cases that Marilyn just presented, and when we talked, we tend to think about the uterus and the ovaries, but the pelvis, and then even going beyond that, our peritoneum and nearby structures, they often really hold silent information that can really shape fertility, gynecological health, and our overall well-being. So MRI does allow us to sort of widen the lens, right? We're not just seeing the organs, but we're seeing the neighborhood that they live in. So of course we have to remember though, that the reproductive story, it often begins in the brain, and the MRI lets us see that chapter too. So Marilyn has a couple more cases, and one of them is going to really highlight how sometimes what looks like an ovarian dysfunction is actually maybe even adrenal driven.
Yes, Dr. Ashley, this is actually a great example of how whole body MRI can detect silent but fertility impacting conditions before symptoms even arise. So here we have a young female who came in for proactive health screening with no specific complaints. Her MRI revealed bilateral hydrosalpinx, which is dilated fluid-filled fallopian tubes, which you can see here on both her axial and her coronal views. These tubular structures are easily traceable from the uterine cornea toward the annexa. And on T2 weighted imaging, the fluid signal appears bright, and the coronal stir sequence helps us distinguish the looping structure of the fallopian tubes from other adnexal cystic lesions like ovarian cyst. From a radiologic perspective, this is a clear-cut case. MRI's soft tissue resolution allows us to visualize not just the size of the dilated tubes, but also their continuity, location, and orientation, features that would be very difficult to fully assess with ultrasound and often missed entirely in asymptomatic patients. Why does this matter clinically? Well, because hydrosalpinx can silently affect fertility by blocking sperm transport or impairing implantation. It can also increase the risk for ectopic pregnancy or a miscarriage. And yet many patients won't even know they have it until they're struggling to conceive, or it's found incidentally during fertility workups. So in my consults, this is where the value of whole body MRI becomes very clear to the patient. I'm able to explain not only what we found, but why it matters now, even before symptoms or reproductive challenges begin. And importantly, we've done this with a radiation-free modality that can guide early gynecological referral and potentially fertility-preserving intervention. So again, this case highlights how MRI screening adds depth to the annual physical. We're seeing pathologies that impact long-term health and quality of life in patients who might otherwise be told that everything looks normal. And then for my next case, this is a classic example of the type of incidental but clinically relevant findings we often uncover during a whole body MRI. In this case, we have a small adrenal adenoma in a young asymptomatic woman. The MRI here revealed a left adrenal lesion measuring 0.8 centimeters located in the medial limb of the adrenal gland. What supports the diagnosis of a benign adenoma is the presence of what we call signal dropout, and that's a key radiologic feature typically seen on what we call out-of-phase sequences, indicating intracellular lipid content. This is a reassuring finding that helps us distinguish adenomas from other adrenal masses. From a radiology perspective, it's not just the size that matters, but its characteristics. And this lesion, while benign in appearance, isn't something we ignore. Adrenal adenomas can be hormonally active, even when small, and they can influence cortisol, aldosterone, androgen production, and sometimes subtly, but sometimes significantly. So in my consultations, this becomes a teaching moment. I explain what the adrenal glands do, what this lesion might mean, and how it connects to broader endocrine function. Often the next step is biochemical evaluation, not because we expect pathology, but because we're being very thorough. And just as importantly, this was found before symptoms emerged, giving the patient time to monitor, follow up, and intervene if needed. That's a key message in this webinar. Whole body MRI helps us spot early silent changes that can guide smarter, more proactive care, even in patients who feel fine. And with that imaging site, I'll hand it back over to you, Dr. Ashley.
Thank you. Those were really great cases. All right, so if we move into our other more common physical that we may come across, of course, our patients are going to move out of the young adulthood. They start living their lives. It looks very different, and they're no longer probably just taking care of themselves. Now we're trying to balance work, raising children, and often starting to look after aging parents for a lot of folks. So that's that sandwich generation that I brought up before. They're stretched thin, and often their own health gets kind of neglected. So if we recognize this type of patient when they come in for their physical, our traditional focus in a regular physical is going to be starting to talk about cardiometabolic screenings, doing blood pressure, cholesterol checks, and then early cancer screenings. A gap that we could have in this age group is going to be that they're often too busy to possibly prioritize self-care, or they're not coming in routinely for checkups anymore. So chronic disease can creep up silently for these folks. And so really, when we think about it, a single scan can check for fatty liver, early kidney diseases and tumors, things that no physical exam can really uncover on its own. And so these are the patients who show up exhausted, and their labs will look fine until the day they don't, right? And so this patient might be the one that's saying, I'm going to get to it after soccer practice. I'm going to wait till after my mom's doctor's appointment. And so what if, by when we get them in for that physical, one Prenuvo scan can really buy them either some peace of mind and add sort of that preventive safety net so that they can care for themselves as well as they do for everyone else that's in their life. So some topics that would come up for this are going to be, we can really get some additional insights into liver health as well as what's under the skin. If they say, yeah, I realized that in the last couple of years I put on 10 or 15 pounds. Well, is that going to be subcutaneous or visceral fat, right? And so say once a physician, does discover that there's MRI evidence of liver steatosis or any kind of subtle liver health issues in general, even if someone looks normal and on exams and their labs are fine, the entire tone of the recommendations is really going to shift. And so instead of this generic prevention that we might talk about, the advice becomes really personalized now. It's a little bit more urgent, and it can be anchored in, the visual findings that we see on the MRIs. And so it's not about us wanting to scare our patients more or anything like that. It's showing them these reversible red flags that, could eventually turn into major roadblocks for them if we don't act now. And so the other topic kind of would be that the visceral and subcutaneous fat mapping, right? And so basically in this regard, MRI can quantify things like our visceral adiposity. We can look at ectopic fat. So that's going to be looking for the fat in the liver or pericardial fat or even muscle fat in a person. And we all know that those are all strongly associated with endothelial dysfunctions, insulin resistance, and even accelerated atherogenesis. So unlike BMI, also not the most perfect, but these, what we like to call imaging biomarkers, they really can correlate more strongly with vascular aging and long-term outcomes. And so, Marilyn, I think you're going to show us some cases on this as well.
Yes. So these next cases demonstrate how whole body MRI goes far beyond identifying structural lesions. It also offers quantitative insight into body composition, which is incredibly valuable when evaluating cardiometabolic risk. So on the left here, you see a coronal T1 weighted image that gives us an unprocessed view of the abdomen. On the right, we've applied segmentation software during our body composition analysis that distinguishes visceral fat, the yellow region inside the abdominal cavity, from subcutaneous fat, which lies beneath the skin. And this distinction matters because visceral fat is strongly linked to insulin resistance, inflammation, and cardiovascular disease. Subcutaneous fat, by contrast, tends to be less metabolically harmful. And the challenge is you can't see this from the outside. A patient can appear completely normal weight or even lean, but carry significant visceral fat internally. And now on the next slide, we illustrate that contrast clearly. The patient on the left has high visceral fat. Note how densely packed the yellow adipose tissue is around the abdominal organs. The image on the right shows a patient with low visceral fat, far less internal fat deposition, despite similar external appearance. Clinically, this changes my consults dramatically because instead of saying you should try to lose some weight, I can now say you have a specific fat distribution pattern that increases your metabolic risk. Let's target this with like some strength training, some specific dietary changes, and possible referral to either endocrinology or nutrition. And on the next slide, we see how more segmentation of fat, and what's more, we can track these values over time. So if a patient starts GLP-1 therapy, for example, or adopts a new lifestyle regimen, I can objectively show them whether visceral fat is decreasing, which reinforces patient motivation and patient engagement.
All right, as we move into our third kind of case, again, similar age group, but some of those same people, they also might live in these high pressure roles. They may, unfortunately, just have a lot of deep stressors in their life. Again, CEOs, surgeon, first responders. But for them, stress isn't an occasional inconvenience. It's actually a daily reality. And so they may look like they're thriving on the outside, we know, but inside, stress leaves its fingerprint on the body. So traditionally, again, if we recognize this patient, they're coming in for their physical, we may be talking about things like stress management, doing some mental health assessments, doing things again with blood pressure, and maybe even some sleep hygiene conversations. A gap that we might get from our routine annual physicals for this patient could be that we're really, really looking for stress, like how stress's hidden toll can be on the body. So we're not always thinking about the silent vascular disease that could be going on, the adrenal pathologies, or the stress-related GI issues even. And so for this case, I want us to think of the executive who travels weekly. They're powered by maybe caffeine and adrenaline. And so they're really going to complain, but what if a Prenuvo scan can reveal what stress is silently reshaping in them? Whether it's early vascular disease, those adrenal changes, this is where the prevention becomes personal. And so a big topic for that's going to be, just looking at the early signs for cardiovascular and vascular aging. Vascular aging continues to be the pathogenesis of hypertension that is our bread and butter, atherosclerosis, stroke, heart failure. So traditionally, we're going to assess, our assessment for this kind of lies on getting blood pressures, lipid panels. Hopefully, they might be coming in even for clinical events that are happening, chest pain and such, which are pretty late stage markers. And so the concept of early vascular aging, or EVA, suggests that we can detect subclinical deterioration decades before symptoms. And Marilyn, you've got a case to kind of exhibit this, right?
Yes. So this case here is a perfect example of how whole body MRI can provide clarity when patients present with vague or like non-specific symptoms. So our patient here is an adult male with bilateral leg swelling, concerned about circulation issues, and also worried about a family history of pancreatic cancer. He came in for a whole body MRI, hoping to get a comprehensive look at his health. What we found instead was a clear picture of congestive heart failure. So here the MRI showed cardiomegaly, an enlarged heart, occupying more space within the thoracic cavity, as well as pulmonary edema, seen here as thickened interlobular septa, sometimes referred to as curly bee lines. In addition, he had bilateral pleural effusions or fluid collecting around both of his lungs. Taken together, this triad, cardiomegaly, pulmonary edema, and the pleural effusions, strongly supports the diagnosis of CHF and provided a definitive explanation for his leg swelling. It also ruled out a pancreatic mass. Given the fact that the patient was concerned for that, it provided him with peace of mind on that front. From a radiologic standpoint, what's remarkable here is that MRI is not typically the first-line tool for cardiopulmonary conditions, yet it still delivered diagnostic quality insights that helped redirect this patient's care, all without radiation or contrast. And clinically, this changed the consult conversation, right? So instead of investigating vascular or oncological causes of swelling, we were able to prioritize a cardiac workup, including labs, echo, and possibly a cardiology referral, and we were no longer guessing. This is a great reminder that whole body MRI isn't just for finding cancer or structural lesions. It also helps uncover functional conditions early, especially in patients who have been bouncing around the system without clear answers. And my next case, this is an incredible reminder of how whole body MRI can uncover silent conditions with serious consequences, even in patients who believe they are healthy. Here you actually have a 67-year-old woman who presented for routine whole body MRI. She reported no symptoms, no known cardiac history, but during the scan, our MRI technologist actually noted that she had a little bit of difficulty consistently holding her breath, which raised a little bit of a subtle flag. On review, the MRI revealed a large pericardial effusion, seen clearly here in both axial and coronal views, and the bright fluid signal that's surrounding the heart is unmistakable. It actually measured nearly 2.6 centimeters in thickness. And while this scan, again, wasn't specifically cardiac focused, the incidental identification of this effusion was likely life-saving. Accumulation of fluid in the pericardial sac can lead to impaired cardiac filling, shortness of breath, and in severe cases, cardiac tamponade, a potentially fatal complication if left untreated. So in this case, the patient had no classic symptoms, but looking back, her breath hold difficulty may have been an early physiological clue. Because of this scan, she was referred promptly to cardiology evaluation and was able to receive care before a crisis occurred. This case reinforces the message that whole body MRI isn't just about finding tumors, it's about uncovering hidden threats in asymptomatic patients. It gives us a chance to intervene early, educate our patients, and truly practice preventative care, Dr. Ashley.
As we get to the final type of case and some of the things that we can add in addition to MRI, we're talking that the proactive aging group. So eventually, no matter our path, we all are going to arrive at a stage of life where we're going to start asking, how can I stay independent and healthy for as long as possible? And again, in the world where we have the healthcare shift to a preventative style of healthcare, I think we should all be asking that question a lot earlier. But this is the proactive aging patient, and it's someone who knows time is precious and wants to invest in longevity. Traditionally, right now, our focus in this type of age group physical exam or wellness checkup is going to be functional assessments, fall risk, cancer screening per guidelines that we have. And a gap can be that guidelines are actually a little bit more piecemeal at this point, some not extending beyond certain ages. And many conditions can remain undetected until they're symptomatic. So I would say that this group really craves that proactive care. Whole body MRI is an opportunity for us to say, we're not just going to wait for problems. We're actively looking to preserve your independence and quality of life. And for these patients, MRI isn't just about finding disease. It's about affirming what's working well, creating a personalized health roadmap for them, and giving them the confidence that they're not leaving their best years to chance, right? And so one area, again, that we're going to see some advances in is going to be looking at brain aging and microvascular integrity. So the brain ages silently before it ages visibly. MRI lets us see the early footprints of decline. So instead of waiting for memory loss, we can measure brain health today. MRI gives us this way to track our brain volume and structure, the way that we would track our cholesterol or blood pressure over time. Microvascular integrity is the foundation of healthy cognition, and MRI is actually our best tool to see it early. Marilyn, this is a case that you've got for us, right?
Yes. So this case actually highlights how whole body MRI can provide valuable insights into cognitive health, even in asymptomatic patients. So here we actually have a 77-year-old man with no current neurological symptoms who underwent our whole body MRI scan with the addition of one of our advanced neural packages that adds enhanced brain volume analysis, and it revealed two key findings. First, scattered white matter hyperintensities, which are most consistent with age-related small vessel ischemic changes, which is a very common but underappreciated pattern. And then second, it also showed mild loss of brain volume, with regional volumes in areas like the hippocampus, the amygdala, and the caudate falling below the 25th percentile for his age. Now, these findings, though subtle, are not insignificant. White matter hyperintensities, as you can see circled here on FLAIR imaging, reflect microvascular changes in the brain's small blood vessels. They're associated with increased risk for cognitive decline, gait instability, and even stroke. So particularly when they become more extensive over time. What's valuable here is not just the presence of these findings, it's the opportunity to monitor them longitudinally. Whole body MRI provides an imaging biomarker we can now track year to year, just like you would your cholesterol or your blood pressure. So in my consultations, I find that discussing brain health in this context really resonates with patients, especially those who are proactive or they have a family history of dementia or neurodegenerative conditions. And this opens the door to like more meaningful lifestyle interventions. We talk about improved sleep, cardiovascular risk management, metabolic health, and cognitive stimulation. We're not waiting for cognitive symptoms to start here. We're using imaging to get ahead of the decline, and that's where the true value lies. And my next case is actually a case that speaks about the life-saving potential of proactive imaging, because here we have a female who underwent a whole body MRI as part of routine screening. She had absolutely no symptoms, no headaches, no neurological concerns, but her scan revealed an intraaxial brain mass in the right frontal lobe, involving both the cortex and subcortical white matter. The lesion is clearly visualized here across multiple MRI sequences on her sagittal T1, on her axial, and on the diffuse weighted imaging, giving us a comprehensive view of its size, its margins, and its signal characteristics. There were no signs of mass effect or hydrocephalus, which further supports that this was found early. After imaging, she was referred to a neurosurgical center, underwent a biopsy, did surgical planning, and was ultimately diagnosed with an oligodendroglioma, a slow-growing but serious primary brain tumor. And she had a gross total resection, the most complete type of removal for this, which is strongly associated with longer survival and improved outcomes. Why does this matter? Because gliomas like this are often diagnosed late, when patients start having seizures, when they have cognitive decline, or when they have personality changes. But thanks to this proactive scan, this patient was treated before any of those symptoms ever emerged. And that's the difference between reactive and preventative care. In my consultations, I often emphasize that not all the most dangerous conditions give you early warning signs. This case proves that, and whole body MRI gives us the chance to change someone's story before they even know their story is being written. So for providers, this is a reminder of how whole body MRI can support truly comprehensive screening, not just for cancer or cardiovascular risk, but for silent neurological diseases too.
All right, so another big topic we can get, when screening this age group or really, any of our adult physicals is going to be talking about musculoskeletal and spinal degenerative changes that we might see. So for the proactive adult, MRI can reveal those silent wear and tears. That could be your disc bulges, early arthritis, or even bone marrow changes before they really start to turn into pain or disability for somebody. And so aging well isn't just about adding years. It's about proactive movement, strength, and freedom. So MRI really gives us that blueprint. As Marilyn's been kind of describing throughout, this is one of my favorite sections in our consultations, whether I'm talking to someone in their late 20s or 30s, all the way up into someone in their 80s. But at the end of the day, when we find these sort of like early signs of wear and tear, or just the things that someone may be asymptomatic for, this is one of our areas we get a lot of ability to sort of provide some very good next step preventive ideas, whether it's future physical therapy, working on strength training and such. And you can really see sort of the light go on in someone thinking about, some very specific steps they might want to take in the next year to sort of strengthen these areas. And so, Marilyn, you've got a case for this as well, right?
I do. This is actually my final case, and it shows how whole body MRI adds value by identifying structural spine changes that can impact mobility and quality of life, sometimes long before symptoms become significant. So on the MRI, we actually see moderate degenerative changes in the cervical spine in this patient, specifically at the levels of C4, C5, C6, and C7. And these are described as disc bulge osteophyte complexes with varying degrees of canal and foraminal narrowing. These findings are subtle but cumulative, and they can explain symptoms like neck stiffness, radiating arm pain, or intermittent tingling, even when not yet disabling. Radiologically, we're seeing flattening of the thecal sac, posterior disc bulging, and early spinal canal stenosis. What's helpful about MRI here is the detail. So we can see the degree of narrowing, the contour of the spinal cord, and whether nerve roots are being compressed. Clinically, I use this information in consults to start a preventative conversation. Even if the patient is asymptomatic, this is an opportunity to talk about posture, ergonomics, and muscle strengthening to reduce future progression. And if there are mild symptoms like intermittent numbness or stiffness, we can validate their experience and guide next steps early, whether that's physical therapy, spine evaluation, or imaging follow-up. It's very helpful. Ultimately, this reinforces the idea that musculoskeletal health is part of preventative care. We're not just looking for disease, we're also identifying risk factors for pain and mobility decline. And whole body MRI gives us that chance to intervene before the patient's quality of life is compromised, Dr. Ashley.
Very good. All right, so Marilyn and I wanted to sort of, capture sort of the key takeaways and things that can really, and summarize again what you guys can really think about of the core concepts of today's materials in your physical exams. The first being that, we're now going to really try to help our physical exams move away from giving generic lifestyle advice to a more personalized metabolic strategy for our patients. And so I know for me, if I'm doing a physical exam and I don't have MRI, I'd be giving some broad advice, saying, maybe try and exercise, eat clean, and to maintain a healthy weight.
Yeah, but now after the MRI, you can point to exactly what type of fat they're carrying and where, and have that discussion and be more detailed so that the patient is more likely to comply.
Another key concept what you might actually change is you're not going to go from this age-based screening to what I really like is the risk-based personalization. So before, an MRI, conversations are really driven by those check boxes that we all love. Okay, hey, you're turning 45, it's time for this or maybe that. And it's this kind of one size fits all model. It's helpful, but in reality, it's quite limited.
Yeah, but Dr. Ashley, now after the MRI, the tone completely changes. I now get to say things like, we found some early liver fat accumulation or small benign cysts in your kidneys or your ovaries. I'll get to tell them if it's urgent or not. And I'll talk to them about clues that their body is starting to shift in different ways that are worth watching. And that gives us the opportunity to intervene earlier, whether that means adding labs, imaging, or tailoring their care plan sooner than the general timeline suggests.
Another type of thing that can change is we're going to go from abstract prevention to targeted organ monitoring. So again, before I'm going to say something like, we'll keep watching your labs each year, and we're going to hope to catch, changes early. It's well-intentioned, but it's very abstract, right? Especially if the patients actually feel fine.
Yeah, but now after the MRI, you get to say things like, we're also tracking things like your liver fat percentage, your visceral fat, your organ-specific changes that are occurring over time. And so that will help us see whether your lifestyle changes are actually working or not, and we can continue to modify if needed.
And then a final, ways that the conversation might change is we're going to go from discussing things from a watchful waiting perspective to proactive screening. And so traditionally, we're telling our patients if your pressure worsens or if your A1C climbs a little bit more, we'll consider more testing. But if time is something, something is visible on an ultrasound or flagged by the time seen on an ultrasound or flagged in the labs, the damage is already underway. And so what would be different with MRI?
Correct. Because with whole body MRI, I've seen patients who had borderline labs, but their imaging showed early kidney scarring or subtle fatty liver or pancreatic changes, which are all signs of chronic metabolic strain that might otherwise be missed. And when I show patients those images and explain what they mean, they become much more open to early intervention, whether that's lifestyle changes or medications like GLP-1s, SGL2 inhibitors, or statins. And as clinicians, we can refer earlier to specialists like nephrology, cardiology, when there's structural evidence, even in the absence of severe lab changes. It puts us in the driver's seat for truly proactive care.
Exactly. So, Marilyn and I hope that we've really made the case for whole body MRI integration into your annual physical exams. Again, going back to my big picture from the beginning, it's really imagining this future where if folks are really getting these lifelong full body scans, it's going to start giving us data about the still healthy bodies, when they're healthy, I should say. Sorry, data really can transform as we know it. And so when advanced screening and administration is more widely and regulatory, we can learn when and how and why certain conditions emerge. We can ask what bodies look like in the decades before the diagnosis. And we can ask whether the diseases that define our span and quality of life, like cancers, dementias, metabolic disorders, are they as inevitable as they appear? We're already taking steps in this direction. We've got, research and data that's coming out that establishes connections between abdominal fat and brain atrophy, between metabolic dysfunction and follicle count in reproductive aged women. And I could list many more. But these insights are what we can help countless patients, and not just the ones who even get our scans. So, in conclusion, whether we're talking about young women just starting out in life, a parent balancing everyone else's needs, a professional under relentless stress, or an aging adult planning the future, one thing is really clear. The normal physical exam as we know it isn't enough. And with Prenuvo, we can redefine it, making it more proactive, more personalized, and a more powerful for every stage of life. So we'd like to thank you guys. And is there any questions?
Guys, that was wonderful. Yes, we do have questions. Let me read these out to you coming from the live stream chat. The first question will be around, the concept that if we're talking about a whole body MRI as part of the new routine annual checkup, what actually is the recommendation for a whole body MRI? Is the cadence the same as an annual? Do we think about 24 months or 36 months? What do you guys think about that?
I think that we really feel that for your average age adult, that it would be part of their yearly. If that's their cadence of going in for their annual physical, then 1 year is going to be good. We could see scenarios possibly in a much younger age group where maybe that 24 months comes in. But this would be something where we're looking to either see stable findings or catch things, as they occur throughout year to year.
And, just going along with that, the idea that, people are going to ask is, well, what's the science to support that, or what's the literature to support that? Can you guys briefly talk about any information that we've learned from Polaris or from the upcoming Hercules study?
Why don't you speak on that one?
So just from Polaris, what we've learned is that about 2.2% of patients are going to be sort of discovered to have some high risk acute malignant something or another that's considered a category 5 OncoRads or CSD score. So that's something that we find on just a routine annual screening is about 2.2% incidence rate of high risk findings. The true positives on those is about 65% in that neighborhood. The rest of the findings are really a little more subjective, and I'll say that because the findings of fatty liver disease, the findings of liver cysts, the current literature supports the idea that those things can change on average every 6 to 12 months, which is how Prenuvo sort of landed on this 12-month recommendation. So that gives us an opportunity to sort of capture those maybe lower acuity findings before they become higher acuity. So a good screening or service modality. We think about this in equivalence to sort of the annual mammogram. USPSTF thinks about every 2 years. I think most clinicians and the American Cancer Society stick with 12 months. So there's always some debate about the true value of doing these things more regularly or infrequently. But again, we're going on sort of population data that supports this 12-month idea. So again, that sort of matches, I think, the idea of an annual physical exam, right? Another question we received is, does a patient referred by a provider also get a consultation? And then what do the providers receive in terms of documentation or notes?
Yes, every patient can receive a Prenuvo consultation. even if referred, but the provider has the ability to choose. We provide a physician report, which summarizes MRI findings along with some interpretation and observations and recommendations that are made by our radiologists, which are the basis of our consultations. So it's really up to you.
And then the last question to just come through, what are the age requirements for getting an MRI? Is it limited to patients over 18?
Currently, yes, we are doing it 18 and older at this time.
Yeah. Any age restrictions?
There are some size restrictions. Sometimes I think our MRIs go up to 450 for weight. It might be 550, but I do think that there's also more about your diameter that we would have to look at for that as well.
Yeah.
And then our height, there's not really a height cutoff so much as the ability to see, from above the ankle and such in that regard. If you're over about 6 foot tall, we're not going to likely see the ankles.
And then I'm getting a few questions about cost to the patient, cost to the provider. I'll be happy to answer those in the chat because those answers actually kind of do vary a bit depending on the agreement that you might have with Prenuvo. But my understanding is that the retail price for a Prenuvo scan, so a direct-to-consumer price, is actually somewhat higher than the price that they would pay going through a partner physician or provider practice. So that's something that account managers would be able to kind of figure out with you on a one-to-one basis. Then the last question here, implanted device restriction. Are there any restrictions on implanted devices?
Yes, like your typical MRI safety considerations need to be in place here. So like major cardiac stents, implants, there's certain, if they're not MRI safe or MRI compatible, then yeah, we need to take that into consideration for sure for safety reasons.
Okay. And sorry, last question, and this is maybe more from me. What is the process for expanding into additional locations? So yeah, that is something that we are always debating and talking about here at Prenuvo is sort of our expansion strategy. If you guys look at our expansion map right now, we've already kind of highlighted what our roadmap for 2026 and 2027 will look like. So I encourage everyone to take a look and see our prenuvo.com/locations website. And that kind of gives you an idea of where we're already planning to go. Now, if you've got other suggestions for where we should be going, I would be happy to field that. So I'll put my email address in the chat, and anyone who's got any kind of significant ideas about where we should be looking to expand, I'm always happy to hold those conversations and share that with our expansion team. And sorry, one last question here. What slice thickness do you consider safe and appropriate for whole body MRI and preventative screening? And what is a typical range in millimeters? That's a great question.
Yeah. So what we're doing currently in our screening MRIs in the brain, we're doing about 3 millimeter slicing. And then throughout the body, depending on where we're at, we're probably anywhere from 5 millimeters to a centimeter in thickness.
Perfect. And that's, I believe I know the answer to this, but maybe y'all do as well. The OncoRADS criteria that we are using to help score our findings. Do we know what the actual threshold levels are for OncoRADS scoring?
Generally lesions that are about 2 centimeters in size, correct?
So we're actually falling below that threshold in a good way. So we are actually detecting lesions smaller than the OncoRADS requirements to be considered an OncoRADS 2 through 5 lesion. So I think that's an important, statement to make for providers is like, okay, the threshold is going to be 2 centimeters for OncoRADS. We're detecting down to about, we say, I think 1 centimeter on our website. In different parts of the body, different penetrance, we can get down to 5 millimeters, I think. And the science is still evolving. That number is going to keep getting tighter, but we're still not perfect. And Marilyn Galvez actually coined this term that we're a see a lot exam, but we're not a see everything exam. And I use that all the time. So I really think that's an important concept to have our providers also think about is if you have a patient with like a 2 millimeter lung nodule, a 3 millimeter thyroid nodule, those things actually fall below the threshold for our detection. Doesn't mean it's not there. And, we may say, hey, the thyroid gland was assessed and there was no nodules visible. That doesn't mean that we're missing it. I'm going to say that falls behind or below our threshold for discovery or for detection. But when you look at all the criteria for how to treat a lung nodule or how to treat a thyroid nodule, it actually falls below those criteria for Fleischner guidelines and for papillary thyroid diseases, et cetera. So that is how we sort of landed on that being a comfortable level for detection. But it doesn't mean that we're content, that we are still working on tightening up those gap thicknesses, those slice thicknesses. And so I do anticipate that number is going to keep shrinking over the coming years with newer technology. And that same provider has asked now, do you use artificial intelligence for your whole body workflow? Great question. So no, yes and no. Every single report is prepared by a radiologist, period. End of story. That every single report is prepared by a radiologist. We do implement AI for some more of the, smaller technical details that go into like sort of measuring Like the measurement that you get for a prostate volume is actually an AI tool that we've developed. But the identification of no prostate lesions, the identification of no prostate hyperplasia, that is pure radiology. We are simply using it for the volumetric assessment there on the AI, but the actual, diagnostic technique is done by a radiologist in every single sequence. And so how does it support radiologists in detecting findings? There it is that the AI is sort of supporting us in sort of direct measurements. I think we are like numbering our vertebral bones with AI. I think that we're measuring endometrial thickness with AI, but we're still relying on the radiologist's own observations and own interpretation to finally make that report and transmit to the patient, to you. Yeah, and sorry, the questions keep coming, but this is great. Are you considering expanding into non-contrast MRA to evaluate coronary atherosclerosis in the future? We're always considering. So, sort of stay tuned on that point, that we are always looking at different options for evolving the test at Prenuvo, that there are different modalities, different sequences, things that are being still developed. And we are always doing research on that end. So yes, the ideal for, I think, every single person on this call is at some point being able to comment on coronary atherosclerosis, on cerebrovascular disease directly on these scans. We're not there yet, but it is absolutely something that we're looking into. Well, I think that brings our call to an end. We're at time. I really appreciate everyone's time. Dr. Ashley, Marilyn, thank you guys so much. This was really informative. A great topic. I think really relevant. Here we are at the beginning of the fall season, and everyone's coming in to get their annual physicals. I think this is a really great time for us to be thinking about how to superpower those physicals in the next year. All right. Thank you all very much. Take care and have a good day.
Thank you, everybody.
Thank you, guys.